blood thinner, anticoagulant, bleeding medication. All of these are appropriate descriptions for warfarin, but what does it really do? Will vampires relish how much it makes you bleed? Is it really associated with purple toes? Can one pill send you to emergency triage for unstable plasma? And what is INR anyway? All of that and more right after the title card. Hello folks, my name is Patrick, and welcome to this informational video on Warfarin, a drug commonly known as a blood thinner. This video is broken up into two parts. The first part will be useful to basically everybody, especially if you're a patient taking Warfarin, and we'll answer questions like, what is it used for, or how should I take it? The second part of this video will be a deeper dive into Warfarin's drug package insert. We'll be using some more technical terms and even have some analysis on its place in therapy. Regardless, I do want to lead off with a usual disclaimer and a reminder. If you are considering taking Warfarin, talk with your prescriber or other healthcare professional like a pharmacist. They will know your situation better than I certainly can and can help better guide you towards making a therapy decision that works for you. Alright then, so let's start with the basics. Warfarin is also known as the brand name Coumadin most commonly. Jantavin is also a brand name for it, though I don't see it as much these days. Warfarin comes in tablets, and they're used as an anticoagulant. That is to say, it prevents your blood from pooling up and forming a clot. And so its purpose in life is to try and prevent those unwanted clots that could lead to strokes, heart attacks, or anything related to that, especially in patients who have risk factors for it, such as atrial fibrillation. Now, before starting Warfarin, there might be a few things that you would want to discuss with your doctor first, just to make sure everyone's on the same page. Per usual, you should be discussing your medication history and any related conditions that you have with your prescriber before starting Warfarin. They'll also want to know about your diet, especially if you eat a particular amount of leafy greens, whether you are pregnant or planning to become pregnant, having any surgeries lately or in the future, and if you have any family history of relevant conditions, such as stroke and heart attack. All of these may impact how safe it is for you or how viable it is for you to take Warfarin. Alright, so let's say you started a Warfarin regimen. How might you be taking these tablets? Warfarin is typically taken once a day by mouth at a consistent time during the day so that the levels of the drug remain relatively stable, and Warfarin tends to last a longer time than other drugs, so once a day is perfectly fine for this. If you happen to miss a dose, no need to worry. You can still take it if it's the same day, but if it's already the next day, go ahead and skip the missed dose, and don't double up on the dose to return back to normal. Just take your normal dose as regularly scheduled once it's the next day. Alright, so let's talk storage and handling. How might you be storing Warfarin when you're not taking it? We're going to go back to the good old phrase, a cool, dry place away from light and children. Cool is roughly room temperature, and that's defined around the mid-70s in Fahrenheit, so that's 15 to 30 degrees Celsius and 60 to 85 degrees Fahrenheit, roughly speaking. Dry is referring to being placed away from moisture, so I'll say this almost every time, the bathroom medicine cabinet probably isn't a good idea. Puffy pills is not a fun story for anybody. And then away from light, this is because light can make Warfarin degrade faster, so we want to make sure that it's not hitting its expiration date sooner than it otherwise normally would. Okay, so let's say you've been on Warfarin for a while. What can you reasonably expect while taking this medication? As far as the side effect forecast is concerned, it's mainly bleeding. Warfarin slows down the rate that clots form, and so if clots aren't there to stop the bleeding, then you'll probably bleed for a little longer or more often here. So bruising and minor bleeds like nosebleed is pretty common while on Warfarin. So it shouldn't get too extreme though, but if it does, then these next few points might be relevant for you. For example, vitamin K reverses Warfarin action, so it'll make your blood clot a little bit faster, and so if you're getting a lot of it from, say, leafy greens or a vitamin pill that you're taking, then you might find that your warfarin dose is stronger to compensate for it, or the other way around, where you might not be getting enough vitamin K all of a sudden, or you stop taking your multivitamin, and then all of a sudden your usual warfarin dose might be a little bit too much for you to handle, and so you'll need to work with your prescriber to figure out a dosing that works for you. Now, to determine warfarin dosing, prescribers usually measure what's called an INR, or International Normalized Ratio. It's really a fancy name for a sort of calculation that is indicative of how fast your blood clots. And so the higher the number, the longer it takes for your blood to clot. The sweet spot for your INR might vary a little bit. I've seen it range between 2 and 3.5 for a little bit of reference for you here. But regardless, have it tested frequently, especially if you're starting or changing your doses for any of your medications, really, especially since warfarin does interact with a lot of drugs. You will need to work together with your prescriber to figure out, okay, is this the correct dose of warfarin for me? Why did it go up? Why did it go down? And hopefully, through frequent monitoring, you can find that sweet spot and stay there. Now, if you do have to stop warfarin for any reason, such as maybe a surgery, you should note that it does take a while for it to wear off. So, you might still have those bleeding and bruising 2 to 5 days after stopping warfarin. If you are planning for a surgery, just make sure that you let your prescribers know about it, so that and the surgeons, so that they can plan around it and give you recommendations on what to do next. Now, while minor bleeding and bruising is reasonable to expect, if it gets too extreme, then you might have to call the emergency room here and pay them a visit. So if you are in these situations listed on screen, then you should seek medical help right away. So this includes, but is not necessarily limited to, of course, having an allergic reaction to it. So especially if it's hard to breathe, that's a pretty serious case there. If you find that you are bleeding or bruising way too much and it is starting to pose an immediate threat, then definitely get that medical attention right away, or at least call your prescriber to schedule your next appointment. If you are finding blood or darkness in your poop, your urine, if you are coughing blood or even vomiting blood, then that is also a serious sign, and depending on how urgent that might be, we would recommend getting medical attention right away. So, as such, to prevent these kinds of things from happening, definitely let any of your healthcare professionals know prior to any surgery that you are taking warfarin, or just make sure that they're up to date on your medications in general. This is always a good precaution to take. As well as another thing too is to avoid other medications that can increase your bleed risk, especially ones that are available over the counter. Aspirin is one of them, and in lower doses this might be recommended by your doctor to take, and if so, follow your doctor's orders. But if you are taking aspirin or other NSAIDs, as it were, so things like Advil or ibuprofen as it's also known as, if you are taking those over the counter, those can interact with warfarin and increase your bleed risk. So make sure to avoid those whenever possible so that you can maintain your therapy and not have to encounter any of those situations I just described. Other than that, that's pretty much it. So let's bring up the summary card here now. So this is what you need to know for warfarin here, and a brief summary of what we just went over. Feel free to take a screenshot if you like to have something to quickly reference on hand. And with that, that'll be the end of part 1. Alright, as a reminder, this next part of the video might be a little bit harder to understand if you don't have a medical or a science background. So if you do have any further questions, seek out your healthcare professional, such as a pharmacist or a doctor, and they'll be generally better equipped to help you navigate the informational landscape and make things make sense. For now, though, let's take a deep dive into that drug label and explore its place in therapy and where it shows up on the guidelines. So warfarin is classified as an anticoagulant and is often described as a vitamin K antagonist. This is mostly true. It actually irreversibly binds the vitamin K epoxide reductase enzyme, the C1 subunit specifically, which is why you'll see the abbreviation VCORC1. On screen now is a diagram that kind of further illustrates warfarin's actual mechanism of action and where it plays a role here. So normally, vitamin K is actually recycled and is reduced to a form that is used in coupled reactions to catalyze the activation of coagulation factors or thrombin. It also catalyzes the activation of anticoagulation factors. So we've got both the gas and the brake pedal being enabled by vitamin K here. Once it's oxidized, it uses VCORC1 to get regenerated into normal vitamin K and repeat that cycle. Now, when warfarin jams up that cycle here, you actually induce a hypercoagulable state first, and this is only because proteins C and S degrade first. Their half-lives are 18 and 24 hours respectively, and so if you don't have a brake pedal anymore, you only have a gas pedal, and so all of the coagulation factors and thrombin are still in play until their half-lives expire, and there's no more usable vitamin K to regenerate more. So factors 9, 10, and thrombin have half-lives of 24, 36, and 50 hours respectively, which is why you have to wait for that anticoagulant effect to, well, take effect. This is reversible via administration of new vitamin K. So as you can see from the diagram, VCORC is only at the step between oxidized and normal vitamin K. So if you introduce normal vitamin K, you can get the reduced form even though warfarin is inhibiting VCORC1, and get those activated clotting factors again. But this might take a while if the patient's stores have been fully depleted. Typically, it should take the liver approximately 2 days to synthesize new ones. So bear that in mind if you are trying to reverse toxicity here. Whew, that was pretty intense, but it is worth knowing the mechanism, since that's the reason why your INR levels can fluctuate in a patient, especially when they're getting vitamin K intake. Let's move on to FDA uses here. So specifically, the FDA has approved warfarin in the use of prevention of thromboembolism when the patient has a history of atrial fibrillation, a prosthetic cardiac valve, or post-myocardial infarction. Off-label use for warfarin is often seen in the context of antiphospholipid syndrome, glomerulonephritis, and anticoagulant therapy when it's genotype guided. So if you have some genetic testing going on, there have been some cases where warfarin is indicated there. Now, the adverse drug reactions is pretty expectable. I mean, it's hard to not say bleeding when it comes to an anticoagulant. More specifically, the monograph states fatal and non-fatal hemorrhage from any tissue or organ, and also general GI disorders, so typical of most drugs, nausea, vomiting, diarrhea, that sort of thing. Some more serious side effects that might be a little bit more rare but are reasonable to expect are skin necrosis or other tissues as well, and of course the hypersensitivity reaction that any drug can elicit. As far as warnings and precautions that are specifically mentioned, the warning for hemorrhage should be very obvious, and tissue necrosis, again, is brought up. This can lead to amputation if unaddressed. Warfarin also has the risk of releasing atheromatous plaque emboli, so make sure that this risk is accounted for here, and use with caution in patients with hepatic impairment. So since there is hepatic impairment warnings in play, you're probably expecting a CYP interaction, and warfarin has quite a few. Warfarin is indeed a substrate of 2C9, and that's the major CYP enzyme that is responsible for its clearance, but you'll find warfarin hanging around good old friends like 1A2, 2C19, and 3A4 as well. It's also worth noting that the bleed risk, of course, with other medications, intentionally or unintentionally, or supplements or foods, is stacking. So if you're having a patient that is experiencing constant bleeding, this might be what you look out for first. Possibly the INR can change with the administration of specific antibiotics and fungals. This was mentioned. And then, of course, as you might expect, changes in the vitamin K intake of a patient will change the INR. So bear that in mind and try to account for that. We'll go over some strategies later. Now, warfarin is no stranger to contraindications, and first up on the list is heparin-induced thrombocytopenia, or HIT as it's more commonly referred to as. Pregnancy is also on the list, although pregnant patients with mechanical heart valves is considered category D, so you can certainly do a risk-benefit analysis for those patients. Hemorrhagic tendencies and blood dyscrasias are the next items, as well as recent surgery involving the central nervous system or the eyes. Those can be pretty sensitive here as well. Malignant hypertension is also a no-no here, and then if the use of major regional or lumbar block anesthesia is in play, warfarin is indeed contraindicated on the package insert. Now, for black box warnings, warfarin fittingly has one for bleeding risk. So it can indeed cause major or even fatal bleeding. So with warfarin, it is important to monitor the INR regularly in all patients, especially when starting or changing doses. The INR can be affected by other drugs, their diet, and other factors. So it's important to instruct patients about the risk minimization measures that they can take. So what should a patient be dosed with? Well, dosing is going to be individualized by their target INR values. Now, most INRs will fall between the range of 2 and 3, but depending on the context, the target INR will vary. Of course, an INR greater than 4 is known to provide no additional therapeutic benefit, so generally by then your patient is going to be bleeding excessively. Most of the time, the target will be 2.5 with a range of plus or minus 0.5 in either direction, but for patients with certain heart valves, this target might change to 3 plus or minus, again, 0.5. So that is the summary of dosing there. It's going to be titrated, and you're probably going to have an institutional workflow to assist with finding the right dose for a patient. Now, in special populations, again, pregnancy, it's contraindicated unless there's a mechanical heart valve in play, so that would be category D. In pediatrics, there's no evidence for use here, so not necessarily the best choice. For geriatrics, they might respond stronger than normally to warfarin therapy, so dosage adjustments may need to be a little bit more proactive about that. No adjustments for renal impairment, thankfully, but again, as we discussed, use with caution with the hepatically impaired patient due to that laundry list of CYP interactions. So the INR is definitely the magic number that we're going to be monitoring here. We want to look for appropriate ranges in all patients, and generally speaking, 1 to 4 week intervals for rechecking is generally accepted. Of course, you want to do that more frequently, especially if there's a lot of medication changes or even disruption in a patient taking a medication is happening. As far as safety monitoring specifically, the only thing that they say is to monitor for adverse events, obviously all of the bleeding related stuff, especially with high INR spikes. And so if you see a patient's INR is on the rise, you might want to counsel them on making sure that they're reporting everything that might be going on, especially if it's involving a lot more bleeding than usual. So where does this leave warfarin? Well, you still find warfarin in the current chest guidelines. And so for venous thromboembolism in the 2016 version, you do see warfarin in there, but NOACs are preferred over VKAs like warfarin. And in AFib for 2018, same story. NOACs are preferred over warfarin in this case. So you might be thinking by now, what gives? Well, this leads me to my takeaways pretty handily here. So warfarin is still used in practice for a lot of good reasons, and the most obvious one we can think of is not all patients are going to be good candidates for DOACs. So if you find that, say, an agent is going to be poorly received due to a patient's renal condition, then guess what? Warfarin doesn't have any renal adjustments to be made, so that might be a more viable option. And so having options in general when it comes to therapeutic situations is pretty good, assuming that you know the ins and outs of all of those options. And so warfarin has been in use for so long now that we generally know how to manage the downsides of warfarin therapy and all of the good stuff with vitamin K. So speaking of which, I did say that we were going to go over strategies, and one of them that I've encountered in my practice rotations here is that giving a vitamin K supplement to maintain a non-zero level of vitamin K in the body can help it so that INR spikes aren't as drastic when they have a sudden unexpected rise or fall in their vitamin K intake. So maybe they have a big leafy green salad. It's going to affect the INR arguably less than, say, if the patient had virtually no vitamin K in their system and all of a sudden they have vitamin K, well, doing its job. Of course, there are other strategies out there, but this is just one that may work for some patients out there. And again, science is all about sharing ideas and figuring out what works. So definitely keep an eye out for any future publications or papers that go over this strategy. And with that, that's all you need to know for now. Thanks for watching. This video was filmed in February 2022 and reflects the current state of knowledge of warfarin and the conditions that it is used in treating at this time. Most of the information was pulled from the FDA monograph that can be found on Daily Med. And for the most up-to-date information, you might want to visit the FDA website for updated monographs or consult with your fellow or your personal healthcare professionals to see if they have any new guidelines or information regarding warfarin therapy. With that, my name has been Patrick, and whether you're a patient or a provider, take care of yourself out there. Thanks for watching.